Again, so glad you're here. I'm really excited about this talk because I feel like this is one of the topics that comes up a lot. We hear it a lot. We hear it in any support group that we are visiting, conversations with people where they say, seriously, one more med? I don't want one more med. Why do I have to keep being on so many meds? And it's a great and fair question. And I feel like it's a topic we really don't get in underneath. And so I am like tickled pink that this is a passion for Dr. Torres-Yaghi, and it is because understanding it helps us make sense of it. And I'm not going to take a lot of time with this because it's a topic that I know you guys are probably going to have a lot of questions on. Again, we'll see how many end up showing up. Last time we had hundreds and hundreds. And so we needed to watch the chat and ask the questions in order to make sure we could pull together as much as we can. If we can allow for people to unmute themselves, we will do that. We know that that is certainly what Dr. Torres-Yaghi prefers, to have a conversation with you guys. We just want to make sure we can cover as much as we can. So I'm with Anissa again, our Vice President of Programs, and we will tag team to support. We will be spotters ready for Dr. Torres-Yaghi, who, as you know, this is the third part of our series. If you're new to this series, you're not going to want to miss the other ones, and we'll make sure that you get that link for the other ones. We have a whole page on our website just for this series that Dr. Torres-Yaghi is doing. And that we're really grateful for Acadia in helping to kind of bring this forward for us and share with us this. The next one is actually how I think our conversations even started. Session 4 is how we had meeting 1. So we're backing it up and building you up to session 4, and that's not next week, it's in a couple weeks. I don't know, I lose track of time. We'll make sure you have the whole series. They've been building on each other, and today is a talk about what's in your pillbox and that word polypharmacy. So we're really glad to have Dr. Torres-Yaghi with us. He is a movement disorder physician at Georgetown University. He also is the director of the, I'm not going to say this right, but the Movement Disorders and Dementia and Cognitive Center, probably not in that order.
That's perfect.
Okay, and so he is a wealth of knowledge and an amazing human. So I'm going to turn this over to him to talk with you.
Thank you. That's so nice. I wanted to thank everyone again for listening to me. I think this is an important initiative. So thank you, Sarah. Thank you, Anissa, for helping kind of facilitate this sort of conversation. I think when we part of what I do is, as a physician, is really talk to my patients about everything, all of the options, right? We think about non-pharmacologic options like exercise and lifestyle modifications and mental health, wellness. All of those things are very, very important. But when we talk about pharmacy and polypharmacy and medications, it becomes a whole other discussion, and it becomes a very serious discussion. And that's why I wanted to give everyone a chance to be able to kind of talk to me and be interactive, about what it is that, each role that each family of medication that can be used for Parkinson's disease plays, and why we have sometimes our patients on a host of different medicines. I would say one of not an uncommon scenario for me is for my patient to say, "Doctor, I don't want to take another medicine. I'm already on so many. Why can't I just use this medicine that I'm on and just increase that one, or just stay on the one that I'm on? Can you take me off of a few?" And I completely empathize with that because, it's not all about our medicines, right? We're kind of like stuck in our neurology movement disorders bubble, and we're trying to help you as much as possible. I can sometimes have a patient on 10 different medicines just for my disorder, right? The disorder that I'm trying to help. But then what about the heart? What about the lungs? What about cholesterol? What about everything else? It's like we don't want to be short-sighted and just think about our own diseases, right? As neurologists, and we don't want to hurt our patient either. When you think about the Hippocratic Oath, the first thing is not, let's treat patients and give them more medicine. No, the first thing that we have to always swear to when we become a doctor is that we will first do no harm, right? And what is medicine? Medicine is helpful, but a lot of the times the difference between a helpful medicine and a harmful medicine or something dangerous, right? Sometimes is the dose of the medicine that you're using, right? The dose and frequency. So we always have to think about the risks and benefits about any medication. And I wanted to give us a brief run through just verbally of the different families of drugs. And then I wanted to give a lot of time to questions about it because I wanted this to be interactive, so that we have a lot of time because I noticed in the previous sessions, Sarah and Anissa, that we had a lot of questions. And I'd love to, I wish maybe we should do, this is way too much time for everybody in virtual world, but almost like an hour conversation and then an hour Q&A. But let's see if we get through this. And I'm going to be very efficient in how I kind of build the framework about how it is that we think about these medicines. So let's start with our gold standard kind of therapy for Parkinson's disease. And we always have to think about the motor and non-motor, right? When we say we have a lot of different things that we can offer for our patients, it's a lot about how can we help the motor system, meaning tremors, rigidity, slowness of movement, gait impairment. Then how can we help with the non-motor symptoms? And we can do a lecture on this that can last a week, a lecture series that can last a week because there's so much. But let's talk about motoric control, right? How do we help with tremors? How do we help with the motor system? The first thing that we think about, and the most common medicine that I know that a lot of people know about is Carbodopa Levodopa, right? How many of you have heard of Carbodopa Levodopa? Probably everybody, right? And yes, exactly. So the beauty about 2020 care is that there are so many therapies, but that's also hard to keep track of sometimes. So let's talk about the different Carbodopa Levodopa therapies. We have Carbodopa Levodopa, known as Sinemet. Everyone knows why it's called Sinemet, right? It means without emesis. And emesis means nausea, vomiting. Anissa was going to say it. So exactly, without sin or sans in French, right? Sin in Spanish, but I think it comes from Latin. And then emesis means probably Latin as well, means nausea, vomiting. What we used to do in the early 1970s when we first discovered levodopa is just give levodopa without carbidopa. And we noticed it gave people a lot of nausea, vomiting. So they added carbidopa to the levodopa, and carbidopa is a dopa decarboxylase inhibitor. And so what it did was in the blood, when you take a drug, it goes in your mouth, down your esophagus, into your stomach. Carbodopa levodopa gets absorbed in the jejunum, which is the second part of the small intestine. So it has to travel that far before it gets absorbed along the way, but it gets really absorbed in that second portion of the small intestine. So then it goes into the blood. Then it has to go from the blood into the brain. Now, what carbidopa did was it allowed for levodopa not to get broken down in the blood into a metabolite that caused nausea. So it blocked that metabolism of levodopa. So it almost enhanced, it elevated the amounts of levodopa so that more could go into the brain and then become dopamine. Okay? So that's what carbidopa levodopa is. So we have different formulations. We have carbidopa levodopa as we know it, the oral tablet form that's absorbed. We have carbidopa levodopa oral disintegrating tablet, okay? That still relies on getting absorbed in your gut, but it disintegrates in your mouth, okay? So rather than have to swallow it with water necessarily, you disintegrates in your mouth. That's the oral disintegrating tablet form. The other form is the more recent form is called Rytary, right? That's the extended release formulation of carbidopa levodopa. What that is, it's a capsule with pellets inside, and the pellets is a combination of immediate release, carbidopa levodopa, and extended release, carbidopa levodopa. Of course, you have controlled release, carbidopa levodopa, and you have Stalevo, right? Which, you know why it's called Stalevo? It's called Stalevo. Stay, Levo, please stay with us, right? So what Stalevo is a compound that's a COMT inhibitor, another enzyme inhibitor, okay? What Stalevo does is you add entacapone, which is an inhibitor to another enzyme, just like carbidopa is an inhibitor of an enzyme. When you add carbidopa levodopa, you add entacapone to that, that becomes Stalevo. Again, essentially what you're doing is you're blocking an enzyme that breaks down the levodopa. Another enzyme. There's several enzymes that break down levodopa. So what you're doing there is you might be extending the duration of effect because you have more levodopa that's working in the brain to become dopamine. Okay? So those are the different formulations of carbodopa levodopa. And it's helpful to know what it is we're dealing with and why we're using those different medicines. Another important point about carbodopa levodopa. Now, there's also a pump, a duopa pump, right? That's a pump that is invasive in many ways because it's through a gastric tube that goes into then further another tube. But that's carbodopa levodopa. It's intestinal gel that gets delivered on a continuous basis. That's a surgical treatment modality, but is another form, a gel form of carbodopa levodopa. There are things in clinical trials like different pumps that go into the skin of carbodopa levodopa that might be in clinical trials ongoing right now. But the gold standard of care is carbodopa levodopa, right? We even have inhaled levodopa, right? That's a medicine that can be inhaled and it bypasses the gut, and that's used for on-demand therapy of wearing off. But if you think about the category levodopa, it's broad. There's a lot of different options there. Now, how many of you have heard of monominoxidase inhibitors? Good, 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 good. I see some hands. Monominoxidase inhibitors are enzyme blockers, okay? So what they do is they block another enzyme that breaks down your own dopamine. So it's like you block an enzyme that breaks down your own dopamine, you have more dopamine in your blood. And it's able to go into your brain, and then so you have more dopamine sitting around. And so it's a way to kind of enhance, reuse, and recycle your own dopamine, or the medicine that we're giving you, right? So we use it in many cases either early on in the condition, or we use it in conjunction with some of the other medicines. So the names of these are rasagiline or Azilect, selegiline, and safinamide is another one. Safinamide or Xadago. Those are the three more common monominoxidase inhibitors that we use. Now they're monominoxidase B inhibitors, meaning that they're specific to one of those enzymes. And so that's what makes them a little bit more modern in terms of their use. How many of you have heard of dopamine agonists? Okay, good. Dopamine agonists are imposters of dopamine. They look like dopamine, they act like dopamine, they sit on the receptors of dopamine, but they're not dopamine. They look, they feel, they sometimes give you the same effect of dopamine. How many of you have heard of rotigotine? It's a patch, also called Nupro. Extended release, yes, and it's a patch. It's transdermal, so it goes from your skin into your body, and it's replaced every day. It's extended release. How about Pramipexole or Mirapex? Good. Now, we tend to use extended release formulations. There's immediate release, Pramipexole, and there's extended release. Extended release, Pramipexole or Mirapex is given once a day with dinner in the evening. The immediate release, Pramipexole or Mirapex, is given 3 times a day. How many of you have heard of Requip or Ropinirole? Again, good job. Another dopamine agonist. Those are the ones that we tend to readily use. Again, extended release formulations tend to be helpful. Now, we've talked about some of the motoric control medicines, right? We talked about monominoxidase inhibitors, dopamine agonists. We talk about carbodopa levodopa. What else is there? There's a lot more. So we have the older medicines like trihexyphenidyl, which is an anticholinergic medicine. How many of you have heard of trihexyphenidyl? Artane. It's an older medicine, okay? And it's an anticholinergic medicine, so it kind of increases the amount of dopamine in the body. Now, how about Amantadine? Have you heard of Amantadine? Good, Amantadine, again, there's a newer formulation, extended release formulation of Amantadine. And then there's another extended release formulation of Amantadine, also called Gocovri. So there's Osmolex, which is one extended release formulation, and then there's Gocovri. Gocovri is used, Amantadine can help increase the outflow of dopamine, but it can also, I'm sorry, that's my phone. I can't get it right now, but it can also help with levodopa-induced dyskinesias. So if someone's dyskinetic, we might use Amantadine to help kind of stabilize and increase the amount of dopamine, but at the same time, it blocks a receptor that might help improve dyskinesias. So those are kind of the ways we think about all of the motor medicine. There's one more, a couple more that are more recent. There is one medicine called istradefylline or Nuriant. Now, that is an A2A receptor blocker. What that means is essentially in Parkinson's disease, our dopamine medicines help step on the gas, right? So our movements in Parkinson's disease are slow because of the disease. Our dopamine medicines and all the ones we went over pretty much help us step on the gas. But in Parkinson's disease, our foot is on the brake too. So it's like we're trying to drive a car with our foot on the brake and our foot on the gas at the same time. It's hard to do that, right? So there's a medicine called istradefylline that helps us take our foot off the brake. So there's two pathways in the brain that lead to movement, the direct and indirect pathway. The direct pathway is the gas, the indirect pathway is the brake. Now that's a lot of information. Now let's talk cognition. What about cognition? How many of you have heard of donepezil or rivastigmine, Aricept or Exelon? Good. Those are the medicines that help us with cognition, right? We think cognitive impairment, if it happens in Parkinson's disease, we have medicines that we can use. Those medicines are enzyme blockers again. They block the enzyme that breaks down a chemical called acetylcholine. So what we're doing is increasing the amount of acetylcholine. Galantamine is another medicine. How many of you have heard of galantamine? Okay, so those are medicines that help increase the amount of acetylcholine. How many of you have heard of Namenda or Memantine? Good, good. So that's another medicine that can be used for cognition. That's a different mechanism. It works on the glutamate receptors, but it's another family, and oftentimes it's used in combination with either Aricept, galantamine, or Exelon. Exelon or rivastigmine is a patch that's worn, and it's been shown to improve cognition and actually improve gait. You know, how does a memory medicine improve gait? Well, it actually might help if you improve your cognitive abilities. You improve your ability to execute a task like walk. So it helps us. You know, if we improve our cognitive, we're more alert, we're learning, we're kind of soaking in everything that's coming in from our environment, helps us a little bit there. Now, how many of you have heard of the medicines for psychosis? Have you heard of psychosis in Parkinson's? We talked a little bit about it. Does everyone know what psychosis is? Right, psychosis can be hallucinations or delusions. And hallucinations can be, there can be many layers of hallucinations. We talked about it when we were talking about our medication reconciliation talk, but when we think hallucinations, we have to think of visions where you actually see people or animals in the room. There are other types of hallucinations called illusions, where you look at something and it looks like something else, right? You can see a belt on the floor, it might look like a snake. You can look outside and a tree might look like a person. There's passing hallucinations where you feel like something just passes in your periphery. And then there's something called presence hallucinations, where you feel the presence of someone in the room that might not be there, or something. Then there's delusions. Delusions are fixed beliefs. You can have delusions of concern that someone could be in the house or people are out to get you. Sometimes there are delusions where your spouse doesn't feel like your spouse. Your spouse feels like somebody else. There's also spousal infidelity delusions, where you feel like your infidelity is happening. And so there's different things here when it comes to psychosis that have to be addressed. We have a medicine that we use called pimavanserin or Nuplazid, and that's a medicine that acts on the serotonergic system to help reduce hallucinations or delusions. And so we use it in many cases in patients that are experiencing that. It's called Parkinson's disease psychosis. If that happens, we use medicines to help combat it. There are also other medicines that can be used, but the FDA-approved drug for Parkinson's disease psychosis is pimavanserin. Sometimes we use clozapine. That's also something that can be used. The problem with clozapine is it needs frequent blood draws because there's a risk of side effect risk where you need to make sure you're monitoring your blood. And then we use other medicines sometimes like quetiapine or Seroquel How many of you have heard of quetiapine or Seroquel? It can be used for psychosis if we have it. But when we think about, probably, from a tolerability and efficacy standpoint, in many cases we use pimavanserin or Nuplazid. Now, that's kind of a lot to unpack, right? And I know it's a brief run through to unpack a lot of things. And that's not all. We have low blood pressure that happens in Parkinson's. There are medicines for low blood pressure. We think midodrine is a medicine. We have fludrocortisone, we have mestinone, and we have a medicine called droxidopa. Just like there can be a deficiency in dopamine, there can also be a deficiency in norepinephrine or adrenaline. And what droxidopa does is it converts into adrenaline and it helps maintain blood pressure. Our patients with Parkinson's sometimes have what's called Parkinson's disease dysautonomia. Their blood pressure runs low. Or when they stand, they're very prone to drops in blood pressure. That can make them feel lightheaded, fatigued throughout the day. Sometimes we have to screen for drops in blood pressure because there are therapeutic options for all of these things. What about depression, anxiety, right? Let's not forget, all of those things are part of Parkinson's. Those are non-motor symptoms of Parkinson's. We use medicines like SSRIs. SSRIs are medicines that block receptors and help increase the amount of serotonin in the body. And what that can do is help you with your mood, helps with depression, reduces anxiety, it helps with sleep, it helps with alertness. And so we do tend to treat depression and anxiety with medicines like Celexa or citalopram, Lexapro or escitalopram. And there's other medicines that we tend to use, but in our practice, those are the ones that we try and use because there's data to suggest that they can help with depression, anxiety, and other factors. What about REM behavioral sleep disorder, acting out of one's dreams? You guys have heard of that, right? There's a part of the brain that controls your body while you're sleeping. It's called the pedunculopontine nucleus. Doesn't matter, but it's in the brain and it's affected in Parkinson's. And what it does is we lose the ability to maintain paralyzed or non-mobile during our REM sleep. So we combat that REM behavioral sleep disorder with medicines like melatonin or clonazepam. There are medicines. So I tell you all of these things not so that we talk about what can go wrong, so that we can talk about all of the therapeutics. This is all about therapeutics, right? This is about hope. This is about empowerment. This is about understanding. And this is about, if we can understand why we use all these medicines and what they're for and why we use different families in conjunction with each other, we can understand why we use so many medicines to combat this disease, right? Because it's a multimodal disease that a lot of the times needs multimodal therapies to treat, right? So now we've talked about the motor symptoms. It's a lot. We've talked about the neuropsychiatric symptoms. We've talked about the cognitive symptoms. We've talked about acting out of our dreams. We've talked about blood pressure fluctuations. Now, that's not everything, but that's a good first start when discussing all of the different therapies that we have. I can always open it up to, and I can talk about the other things. I haven't even talked about constipation. I haven't even talked about injections. You can use injections like Botox to help with stiffness. So if you have stiffness of your neck or stiffness of your leg or other things that happen, we can inject Botox, Xeomin, Dysport, Myoblock. They're all types of botulinum toxin that help relax the muscles. You can also, for drooling, you can inject Botox in the parotid glands and the submandibular glands that help reduce drooling, which can happen in Parkinson's. There's also medicines that help with wearing off, right? Those are apomorphine injections that can help with wearing off. There's a sublingual apomorphine and there's inhaled levodopa, like I mentioned. And then let's not forget the most recent drug that just became approved is called Opipone or Ongentys. That's another on extender. It helps augment the effect of Carbodopa Levodopa. It's like entacapone, but it's an extended release version and it's given once a day. And it might help prolong the effect. I'm sorry, I had forgotten about that for our motor conversation. There's just so much to talk about. Now, there are other factors, right? We talk about constipation. That's in and of itself, that can be its own lecture about the different therapeutics for that, aside from hydration. dietary changes. We even have a little cocktail sometimes, not alcoholic cocktail, but a cocktail of, prune juice and some other things that we put together to help with regulating bowel movements. You think of Dulcolax and a bunch of other therapies. And there are drugs in clinical trials for constipation, because we know if we can help regulate bowel movements, that's going to help absorption of our drugs. So there's a lot to unpack. There's a lot there, but I think that's a good start. And then I'd like to open it up to questions, because we're at the 3:30 mark, and I think we've given ourselves about another 30 minutes to discuss.
And I want to thank you for that. And just so everybody knows, as you're listening to this going, oh my gosh, I didn't get what all of them are. And I totally get that. Promise. Really what we want to have you be able to take out of today is, so the good news is, if he was doing this talk, 10, 15 years ago, he'd be like, hi, this talk will last 3 minutes because I have one drug for you. And that's Carbodopa Levodopa, right? I mean, that was where we were. And so part of this is to understand, really we're doing, because kind of a big picture, global, like complexity. This is why you want to see a movement disorder doctor, because look at all those treatments. But that was beautifully like broken down into kind of the buckets that they help address. So I don't want you to worry that you didn't get all the names. I will put back in, I'm going to interrupt this for a little commercial break, just so I can show you, and you can not, that way I don't want anybody worrying that you didn't see it. So let me quickly just show you on our website. You will find the medication assistance page. It has all of the medication assistance programs that are out there. Let me get this into the full screen so that you can actually see that. It has all of the medication assistance programs. If you need assistance with medication, you can find them all here. Some specific medication information or prescription information and assistance during COVID. And then it has every single one of the FDA approved medications for Parkinson's is listed on here. So, Dr. Torres-Yaghi just went through a bunch of them with you. And you can study this for the next, probably week, because in each one of these, he talked about Mirapex. Let's just look at that. If you click on that, it's going to take you to information about what this drug is. It's pramipexole. And so you can do that with every single one of these medications. He talked about neurions. You go here, it's going to tell you everything you want to know about neurions and their support systems. So on here, I promise it's all here. You don't even have to know how to spell it. And then if it does have it'll have istradefylline. Am I saying that right?
Perfect.
Okay. So you might hear that. You might hear this name. So you'll be able to find all this stuff on our website. If it's not on our website, it's because it's not FDA approved for it. So as he talked about with some of the cognitive stuff, some of these things have been used because there were no other treatments available. So when the FDA says this works for this part of Parkinson's, that's going to go on here. If it's used in a side way, that's not going to go on here. Only FDA approved medications are on here. So I promise we will send this out to everybody too, but I wanted you to know that you don't have to worry that you didn't take notes of all of the different medications. We want you to get how they go together.
I know that was a lot of stuff, but I wanted to give you a brief run through. It wasn't too brief, was it? But a brief run through so that everyone can now, I'd love to discuss it.
Yes. And
I love that website too. That's so great, because I got to tell you, part of the problem is there are a lot of leakage points. When the doctor prescribes a medicine, what's hard is access in many cases. Insurance companies may not want to approve some of the newer drugs, and they want us to prescribe some of the other drugs before trying the newer drugs. And we get stuck in a bind sometimes. So having a website like that where you can look, there are different copay assistance websites that you can sort through, learn about each drug, why it's used. I think that is profoundly important information.
Thank you. Yeah, definitely. And it's why we don't put stuff in print. This is why you don't see slides in print, because thankfully we're in a space where there's new drugs being approved, all different, we've got lots of stuff in the pipeline. So as soon as we print some beautiful book that costs a lot of money, that takes money away from doing programs like this, it's unusable because a new thing gets prescribed or gets approved, which is a beautiful thing. So a website can be added to and keep live, which is why we don't send it to you in a hard copy. So go ahead, I'll let you take it away, Anissa, because you've been tracking the many questions.
I have, and I kind of tried to break them into categories, but the very first one that I want to ask you, Dr. Torres-Yaghi, is one that just came in, that this person wants to know, does patients themselves need to know all this, or can't we let our doctors worry about what they prescribe and why? And they're truly asking, like, why do they need to know? So can we talk about being an advocate for yourself?
Definitely. I think this is a good question, and you're right. We could rely on our doctors to talk about, what to express to you when they think, for example, if we have to add a medicine like rasagiline to your regimen, or have to add entacapone to your carbodopa levodopa, or have to add pimavanserin if you're experiencing any psychosis to your regimen. You're right. It is up to your doctor to kind of think about it and sort through, but at the same time, it's good so that we can educate each other about everything that is related to the pros and cons of every medicine, because each family of drug carries its own risk profile and its own benefits, and they've been studied in many different ways. So an example of that is a medicine like rasagiline has also been studied in terms of studies for cognition, and they showed that perhaps maybe it could have some benefit cognitively, perhaps, right? And so it's good to think about, for example, if someone's experiencing dyskinesias, why is it, what do we do? What are the options? Are the options, trying to lower your medicines because the levodopa induces dyskinesias? But then if we lower your overall medicines of carbodopa levodopa, your dose perhaps, or your frequency, you may not feel the same benefit that you once did. So there are ways to combat the dyskinesias, for example, with a medicine like Amantadine or Osmolex or Gocovri in particular has the levodopa-induced dyskinesia recommendation. So we could use a medicine like Gocovri to help reduce dyskinesias in addition to keeping you on your medication regimen. So understanding kind of the process in terms of why we're thinking, how we're thinking, what drug we use when can be beneficial, especially for everyone, hearing a workshop like this and understanding, hey, I didn't even know there was a medicine to rescue me from an off time. Or I didn't know that if I added istradefylline to my carbodopa levodopa regimen, we might have prolonged duration of effect. It's like an augmenter or an extender of our on time. So understanding that each drug may have its own family, which has its own unique mechanism, and understanding that each mechanism of action can be used in combination. This cocktail-like approach of medicines, combination therapy, oftentimes can lead us down the road of stability if we're in an unstable time during our Parkinson's disease diagnosis.
So to go along with that, someone asked if you could speak to polypharmacy and functional medicine and food as medicine. How does that play into all this?
Yeah, so there's polypharmacy. You always have to know. Part of the reason why we're having this conversation is you always have to know what drug you're prescribing and why. And if you understand the psychopharmacology, the neuropharmacology, in movement disorders, we almost become like a neuropharmacologist because we have to understand all the backgrounds to each drug. And so it is important, understanding the background so that we can think about how it is that we use each drug together. And polypharmacy, not in a way where we're hurting patients, because of course, polypharmacy can mean multitude of drugs that when you combine them all together, could have drug-drug interactions with each other, and then we get into trouble, right? We use the term polypharmacy, but rational polypharmacy. We use them together in a way that they complement each other. They're adjunctive agents to each other rather than fight each other. And that's what rational polypharmacy means. Now, of course, I think food is medicine. You got it. I think it's important, especially when you talk about regulating bowel movements, hydration, exercise, sleep, lifestyle. All of those things make a big difference. The type of food that we tend to think about, well, that's been studied for neurologic conditions. Whenever I get a question about what's the best kind of food for Parkinson's patients. Now, I've been trying since I've started as an attending at Georgetown. I've been trying to hire a nutritionist. Our team has been trying to hire a nutritionist for us, to help our patients understand that if you eat a high protein meal close to when you're taking your Carbodopa Levodopa in whichever formulation, that it can help reduce the absorption of the medicine. And also, so understanding that aspect to your food intake, understanding that, probably the diet that's been studied and has been talked about more recently is the Mediterranean diet, right? Now, what do you mean Mediterranean? Mediterranean's big, right? It's like the North Africa, Levant, Middle East, South Europe, what part of the world are you talking about? What we mean by Mediterranean diet is we mean medicine that is food, right? You look at a plate and you say, okay, is it colorful? Is there fiber? Is there nutrition? Are there fruits and vegetables that have color? Are there berries? Those are fibers. They have fiber, but you want fiber, right? But they also have hydration. If you're going to eat fiber, you also want hydration. What about carbohydrates? Carbohydrates are good. They're so good. You have a big bowl of pasta. Sometimes that's like, gets right to your soul. You sometimes need that big bowl of pasta. You need those mashed potatoes. But when you have carbohydrates in your meal and you have drops in blood pressure, carbohydrates from those starches sometimes can drop your blood pressure even more. It's happened to all of us, right? So we tend to say kind of the Mediterranean diet is lower in carbohydrates, higher in fibers. It actually has some natural fats that come from fruits, vegetables, and meats. But you want as lean meats as you can, but you want the protein intake from those meats as well. So that's kind of what we think. And another big piece is hydration as part of diet, right? We say 64 ounces of water, if you can, if there's no contraindication to a higher volume of water, can be very, very important. Helps maintain your blood pressure. It helps keep you from, a lot of our patients can be prone to dehydration. It's good for your bowel movements. The more hydration you have, the more bowel movements you're going to have. And then Mediterranean diet also means rather than 3 big meals, it means 5 smaller meals throughout the day, like tapas or meze, right? When you think about, Southern Europe, where you have rather than 3 big meals like we do in Northern Europe, maybe, you have 5 smaller portion meals that can help kind of create that kind of grazing-like mentality throughout the day.
All right, so we have a couple questions in regards to side effects to meds. So there was 2 in relation to dopamine agonists. So one was trying to decide between risk versus rewards. So they've been gaining weight. They're not sure if it's because of compulsive eating due to COVID and being stuck at home and bored, or the medication that they started in March. So their doctor warned them that it could happen, but they don't know if it's compulsive or normal. And then another person wanted to know, what could cause a bad reaction with a dopamine agonist, like Nupro.
You got it. So you're right. So dopamine agonists are medications that we use. They can be very helpful. But we always have to think about the risk-benefit profile, right? If we might see good results with a dopamine agonist, before we think about starting a dopamine agonist, we always have to make sure that our patients are not necessarily very past an age where it might be unsafe for them to do it, right? So there are some doctors that won't prescribe dopamine agonists for patients as they're older, as they continue to age. A piece that's important is not to forget their cognitive status. So if a patient is cognitively impaired, it becomes very tricky in terms of our ability to use certain medicines. We want to stay away from some medicines. That's why understanding cognitive impairment can be very helpful. If patients have issues with understanding the factors when it comes to controlling impulses. So whether it be food intake, whether it be impulses to shop or spend money, or whether it be impulses related to other things, hypersexuality, and staying up all night for impulses of having too much energy and not being able to sleep. A lot of those things are important factors. And so this kind of background information of each patient is very, very important. So the reason I bring those things up is because all of our medicines, including dopamine agonists, have a risk profile that when you augment or act like dopamine, you might increase. I usually say there's 5 big things. There's more than that, but there's about 5 big things that we need to look out for. The first one is hallucinations, right? When we think about Parkinson's disease care and hallucinations, it's very, very important because Parkinson's disease can inherently have psychosis, and our medicines like dopamine agonists or Carbodopa Levodopa can enhance that. Drops in blood pressure. Our medicines like dopamine agonists can drop our blood pressure. So if our patients already are predisposed because of their condition to have drops in blood pressure, and the way that manifests itself is with lightheadedness. You know, lightheadedness means a lot of patients might say, I feel dizzy, but in reality, they might be standing, and it's not dizziness like vertigo, it's dizziness, lightheadedness, like I'm going to pass out. Sometimes that's hard to decipher. But if that's happening, it's important to check blood pressure, and there are certain drugs you want to stay away from. Now, those are 2. Swelling of the legs is something else that we always have to watch out for, which can happen as we get older, but also can be due and worsened by our medicines. Falling asleep. So we didn't even get to, some of the sleep disturbances that can happen, but falling asleep during the day when we're not supposed to, doing things like if you were in a meeting or something, or something like that where you wouldn't necessarily fall asleep, right? Napping is fine, but falling asleep uncontrollably isn't. That could be due to the medicine as well. And then the 5th big thing is that impulse control, right? Spending too much money, staying up all night. I had a patient who told me I had put her on a medicine that helped promote her dopamine, and she told me, I can't stop weeding. I keep going outside and I can't stop pulling out the weeds from my garden. And I'm at the point, my husband is looking at me. I'm coming back from gardening. I love gardening, but I've run out of weeds to pull, and I'm starting to pull out the flowers. And I said, hold on, we might have to think about this. Could be some sort of impulse control issue related to the medicine. Let's try weaning you off of the medicine that we started and try and control your motor symptoms in another way.
I'm getting such good questions. We need you for like another hour.
I know. I would. That's
right?
Great. I'm glad. Good. I'm glad.
All right.
Really
so
good.
I think there's so many good questions. So I'm going to ask this one because I think everyone can relate to this. How does a movement disorder specialist interact with other specialists, such as a cardiologist who's managing hypertension? When there's an overlapping condition, such as an OH? Related to PD, so many other conditions? Who should be the captain of the ship? It often falls to the person with PD or the care partner and can be a real hassle.
That one hit the nail right on the head. All of them have, all of the questions have, but that one, you're right. It speaks to, some of the difficulty in care, right? What's good for the heart may not be good for the brain. Lowering your blood pressure, might be something that's important for your blood vessels. It helps prevent any cardiac disease, any future strokes, anything bad that can happen. But if you lower your blood pressure in a patient that has Parkinson's disease, sometimes you're fighting 2 battles, right? In Parkinson's disease, if you have that propensity, if you have what was mentioned, NOH, that's neurogenic orthostatic hypotension, which means it's a neurogenic issue, not a cardiac necessarily issue. But what if we have hypertension because of our overall cardiac status, but at the same time, now I may have had hypertension between the ages of 45 and 65, but now I'm diagnosed with Parkinson's disease. I've been started on Carbodopa Levodopa and maybe another medicine. My blood pressure's low, and I'm on 3 antihypertensive medicines. What do I do now? And that is not an uncommon problem. It's often, you have to work together. You're right. It does fall on the caregiver. It falls on the patient, it is tricky because cardiologists may know what to do with hypertension, and low blood pressure, but sometimes when you're stuck in this middle ground, Parkinson's disease dysautonomia, if you're laying flat, your blood pressure can be like 180 over 110, but when you stand up, it might be as low as 80 over 60, right? And so that's because our blood vessels are made to constrict and dilate depending on our position. Because when you stand, gravity wants to pull blood down, right? And so when you're laying flat, that blood will distribute and it can get high. And so what we do, what's supposed to happen is when we stand up, our blood vessels are supposed to constrict a little bit so that our blood pressure doesn't drop. So it's a dynamic process. But in Parkinson's, sometimes if you have neurogenic orthostatic hypotension, your blood vessels don't constrict and you drop your blood pressure, and that can lead to lightheadedness. So it's a very tricky sometimes scenario, and it really depends on the situation. Oftentimes we'll call our cardiologist and we'll have long conversations. We'll monitor blood pressure fluctuations. We might ask the cardiologist to lower the antihypertensive medicines sometimes. But you're right, that what that speaks to, I think, is again, what this is about: empowerment, understanding the disease, advocating for the patient, being your own advocate, having your caregiver or spouse or family member help advocate as well. Encourage the doctors to speak to each other. Encourage your doctors to look into things, right? Say, look, I'm feeling a little bit lightheaded. What does that mean? Is my blood pressure low? I just wanted to let you know, just like we learned about in our first session, look at all these drugs I'm on. You're putting me on a medicine that might drop my blood pressure even more, neurologist, but my cardiologist has me on 4 blood pressure dropping medicines already. So these things are very hard and they take a lot of understanding. And so that's exactly right. That's not an uncommon problem. Now, I know we have a lot of questions, but I want to mention this. I tend now I have a network of care providers. So for my patients and for patients in general, I say, get a network. If you're able to, if your insurance will help you establish care with a gastroenterologist, a cardiologist, a neurologist, a psychiatrist, a sleep medicine doctor. I know that's a lot, okay? I know it's a lot. But if we could think about a utopian-like clinic, right, that would help our patients the most, I mean, I really think a patient-centered approach to care is the best, where the patient's in the middle and there's a clinic that helps create this kind of patient-centered approach. Say, hey, I know I just diagnosed you with Parkinson's disease, but hey, meet the physical therapist, meet the speech therapist, meet the occupational therapist, meet our social worker, meet our cardiologist, meet our urologist, right? If we could find a way, to keep it all under one roof, or at least one electronic medical record. I'll tell you what I told my own mom. She was seeing doctors that had from different places. She would go see, she liked one doctor that was part of one system. She liked another doctor that was part of another system. I said, look, what would really help with communication between your doctors is find doctors that might be under one system. That tends to help because the electronic medical record, then everyone can share their notes, and that's a really good way to understand cases.
One person just asked if there's an app that can help keep track of meds online so adult children can see what their spouse is taking and can be more involved. And I do know that there are some apps out there. Do you know of anyone that your particular patients are using?
It's a great question. I don't know of anyone in particular, and I should probably learn from, advocacy groups like this. That's a good question to kind of do a little bit more research about. I can now, let me think about that and look into it. I know there are medication tracking applications that you can update. What we tend to do is similar to what we talked about, create a digital medication reconciliation list, like the one we talked about. You could input it in a phone, you could share it. But if you can modify it, I think that's what's good about a digital digital list, is because it can be modified. You don't have to rewrite, the list every time. And I would employ, someone that knows about technology, knows about applications, someone in your family or your friend group, and that we can think about. Because if you have to modify, sometimes you'll come and I'll say, let's modify 2 drugs, at a certain point, and you'll have to go back in and write it out. Some patients actually learn by writing, right? So they'll say, okay, no, now this helped me put it all out. What we used to do before apps, and what helps is the Excel spreadsheet. That's hard too, or just a document like the one that we have that we created through the PMD Alliance. Having a document like that that we discuss can be very, very helpful.
One person asked about whether there is a maximum amount your body can tolerate when you're taking multiple meds for Parkinson's and maybe other medical issues. Is there a point when your body just says, I can't take anymore?
Yeah, so it's a good question. It's very individualized, right? There are some patients that they can't tolerate a low dose of carbodopa levodopa. They might have psychosis when we introduce carbodopa levodopa. There are some patients that can tolerate very high doses. There are some patients that will tolerate, monominoxidase inhibitors like rasagiline, selegiline, safinamide, and carbodopa levodopa. But if you introduce a dopamine agonist, they might have, side effects from them. And so that's why, it's important to persist and try and treat, but at the same time, weigh the risks and benefits. If one family, if a Nupro rotigotine patch or a Mirapex pramipexole or the Requip ropinirole drug cause something bad, that doesn't mean that, if you add another medicine from a different family that you'll have those same effects. And so it's very important, to know all of these families of drugs because they can be used in combination with each other. But you're right, it's not a one size fits all answer. But yes, there are times where, we hit a ceiling, right? If we have someone on a multitude of carbodopa levodopa, high doses, high frequency, they might feel, more lightheadedness. We have to come down on the medicine, or other things. But whenever we get into a phase where we're having, and we didn't talk about this, surgical treatment modalities, if a patient is an adequate candidate for something like deep brain stimulation, if we're experiencing issues where we need more and more medicine, or we're still on the roller coaster ride despite trying to adjust the medication regimen, that's where we start talking about, the surgical treatment modalities like deep brain stimulation and the other ones that I mentioned.
So related to potentially to dysautonomia, someone made a statement is, I don't know if my erectile dysfunction is due to age or PD. So
yeah, it's a good question. Yeah, and so we didn't go so far. We have all the other aspects, sexual dysfunction. And I didn't talk about the urologic issues too much, right? And yes, so when you have dysautonomia, you may actually have erectile dysfunction as a manifestation of that dysautonomia. Urinary retention, constipation, lack of sense of smell, those are all, could be, markers associated with dysautonomia, in addition to the fluctuations in blood pressure. And so it's hard though, you're right, is it the Parkinson's? Is it is it aging? Is it, something unrelated to either of those two? Sometimes it's hard to figure out and distinguish. What is it? Is it both? Is it all three? So it's a hard question. But that's why, having that kind of approach, making sure you speak to a urologist about erectile dysfunction is very important.
Okay, we only have a couple more minutes left. And I know Sarah has some things that she wants to say to end out. So one of the questions I do want to ask is, why is it that doctors don't seem to push or at least offer some of these extended release medications like Rytary compared to immediate release?
Yeah, so can you ask the question again? I'm sorry.
So they want to know why doctors don't always offer the extended release options like Rytary.
Yeah, it's a good question.
As much as the immediate.
Yeah, and that's a good question. And that's why, what Sarah said earlier, you know, this is a field that's changed. It's changing. It's changed. It's, you know, what I learned in my fellowship, which was just, it was a 2-year fellowship, but it was just 3 years ago. Things continue to change. Look, I just mentioned 4 or 5 medicines that I think, you know, they weren't there even when I trained. And so it's very important in an ever-changing field to stay on top of your field. And in certain cases, you may not see a movement disorders doctor, or the way we practice is very different, you know, from institution to institution, from doctor to doctor. And so that kind of communication, that kind of back and forth is really important. Advocating for yourself and asking the doctor, say, please, you know, I learned about this medicine. What are your thoughts about it? You know, do you think that this medicine is right for me? You know, engaging the doctor and challenging them with questions is not a bad thing, actually. And a doctor may be saying the same way that I said, you know, I don't know about the application, like the app on a phone that might be helpful, but, you know, I'll look into it. You know, that's really important. Asking your doctor to look into something might be helpful too.
Wow, this has been incredible. And I have to repeat what Walter said, which is, I like this doctor, good job. And I have to say, I cannot agree more. This is so much information. And again, you're not required to, you know, there is no test after this. And the beautiful thing is it's on video. So you can watch it 500 times and I guarantee you, you'll still learn it the 501 times because it's complicated. And I love what you've brought to this, Dr. Torres-Yaghi, because we know, I mean, information is power. And yes, we want the doctors to say, do this, do this, do this. But to Dr. Torres-Yaghi's point, some doctors have things they use and they don't use this one. And the more you know, the more you can say, yeah, but what about? And is this good? And that's great because this is, you know, your healthcare and this is your life. And so we want you to feel as informed as you can. You don't have to know what goes together. And as you said, Dr. Torres-Yaghi, and I think that is why I am just in awe of the movement disorder specialists that we have such a privilege of working with, because you really are like pharmacists and doctors. And I mean, I just cannot believe the amount of information that these amazing specialists keep in their head. And Dr. Torres-Yaghi, you just shared so much of that with us. I'm not kidding. I'm just it blows my mind. And it is also why, if you don't see a movement disorder specialist, it's why you really, really want to, even if it's once a year. You know, these medications, like it or not, Parkinson's is a subcategory. It's not like depression. So you're not seeing, and the doctors, every doctor is not getting massive information about it because believe it or not, the budgets are kind of small for these kind of medications and they're very expensive to develop. So because of that, the budgets can be small. And so a lot of times the doctors who are educated are really the movement disorder doctors and not even necessarily a general neurologist. And that's not because people don't care. That's because there isn't enough money to do that kind of level of marketing, or else you'd be paying more for drugs. So we don't want that. So part of what we can do is help make sure that you have this information. We have so much information on our website. We, again, will follow up with you. We'll send you the information that we shared. So the website page for this, where you can keep watching this video and review it. Also the information of the medications, all the FDA medications. I loved that idea of kind of maybe we can categorize those by what kind of medication they are. That's a great idea. And we take all your ideas and information, and just like Dr. Torres-Yaghi said, if we don't have an answer or we don't know, that doesn't mean we won't look for it. And somebody put in Metasafe, and I quickly looked that up, and Metasafe looks pretty amazing and free.
Good, I learned. I'm going to check it out.
Yeah, looks really cool. It's a free app that tracks and also shares, and will send alerts if somebody forgets their medication. So pretty cool looking app. I don't know. It took me 2 minutes, so who knows, but it came across on a couple recommendations. This has been, again, an incredible talk. We can't thank you for the time that you offer to us. You are generous and full of knowledge and encouraging. It's encouraging to have these treatment options. It sounds like we're going to need a What's in My Pill Box too. because I
Yes.
think Anissa probably has 30 questions still waiting.
We still have a lot of great questions.
Yeah.
I love it. We'll set it up.
Who wants that? Raise your hand. Shall we do it?
Yeah, I would
all
love it.
right. And while our hands are up, let's wave to Dr. Torres-Yaghi as a great big thank you. You can blow him a kiss and give him a hug and tell him thank you for being with us.
Virtual hug.
Virtual hugs. They're super safe. We hope to see you at the next one. Don't miss the next one. It's a really cool tool he's going to share with you with one of his colleagues, Dr. Miri is going to share this tool that she created. So really glad to be with all of you. Thank you so much. And thank you, Dr. Torres-Yaghi and Acadia.
It's my pleasure. Bye-bye.
Okay. Bye-bye.